So I shall do some introductions and say hello to everybody. I'm going to just repeat my housekeeping there to remind people that yes, we are recording the session because it's really great to be able to share it with members who can't make the meeting today, and we can share that on our Simply Do platform as well. So if you want to turn your cameras off, but please do feel free to introduce yourselves, say where you're from and ask questions in the chat. We've got a couple of presentations today. We have Think Sono with us to talk about their AI guided ultrasounds, and also Nova Bioelectrics, and they design and manufacture devices that interface with the brain and nervous system. So I'm not going to give too much away because I can see we've got our two presenters in attendance, which is brilliant, and I'm going to let them do all their talking. So I think we should start with our first presentation. I don't want to hold up people too much. And we have Fawad with us, I think. I'm sure I've seen you. Yes, hello. There you are. Brilliant. Are you presenting your slides, or do you want me to do that? You're okay to do that?
I'm happy to do it. Yeah, I've updated them as well. So it's
oh, brilliant. That's great. Okay, well, I'll let you introduce yourself and I'll throw the floor open to you.
Okay, cheers. Hello, everyone. Thanks for having me here today. I hope you can see my, this always happens. I always have to make sure my slides get shown properly. Bear with me as I know a lot of people in the NHS, generally speaking, love to use meets, but I don't. so I always struggle to get it. So let me know if you can see my slides.
Yeah, we can see them.
By the way, it says people are waiting in the lobby, just as a heads up.
I think Lara's got an issue with her. It seems to be just the magic spinning around. Hopefully. I'm trying to admit, but I'll keep an eye out on that.
All right. You can see my slides, right?
Yeah.
Excellent. Okay. Yeah. So maybe a little bit about us as a company. So I'm the CEO of Think Sono, and our aim is to improve ultrasound training, or what we call democratize ultrasound across the NHS, basically, hopefully worldwide, in fact. And the key problem we're trying to tackle fundamentally is this lack of ultrasound experience with staff. This 99% comes from, well, I should say the 1% is really, we added the number of sonographers and radiologists basically relative to the number of nurses and junior doctors, etc. And obviously, as you could imagine, there's very few people, relatively speaking, who can perform ultrasound scans compared to those that actually have that experience. And this gap is quite an issue because ultrasound is the least invasive and most portable imaging modality in medicine at this stage, as I'm sure you guys know, and therefore you're sort of losing out on improved patient outcomes and reduced costs potentially due to this lack of experience to use it. The hardware is becoming very inexpensive. The one on the left-hand side you're seeing is like a butterfly device, for example, and it means you can literally connect it to a smartphone and perform scans. So that's less of an issue. Now, to access this hardware, the problem is still that experience. And that's the problem we're trying to solve with AI, basically. And so what we've built is this literally an app. Currently it's on Android, and we will make it available on iOS as well. And this app guides a user, like a nurse, for example, or a junior doctor, to perform various different ultrasound scans. We also have something we called our cloud dashboard. That's optional, but these images can get sent for review if required. And as you could imagine, it's quite flexible, meaning that you can use it for quality assurance, you can use it for training, and hopefully you can also use it for diagnosis. And then we can discuss the various different use cases. Just to show you what that sort of looks like, here's a picture. At the top is a doctor, for example, performing a scan, and they've been guided by our app. And then at the bottom, there is this radiology review. We have like, you can score the quality of the images. In this case, we're looking at DVT, so you can decide whether or not there's a DVT there. But practically speaking, and I know maybe you guys haven't seen this before, but I wanted to quickly show a video. You can access this online as well. I'll send like a link later on. But basically, this shows real time how the software works. I really hope the video is shown there. So basically, you use one of these handheld devices, and we can provide those as well. So you guys don't need the actual hardware. We'll give everything there. And then by downloading our app and having it on a smartphone, now you can perform the scan with the guidance. And to show you what that guidance looks like, I'll slightly skip in this video. It looks like this.
You should see one artery and up to 2 veins.
Basically what it's doing, it's highlighting the relevant veins and arteries. In this case, it's a DVT exam being performed. So there is your artery in red and sort of greenish color is veins. And here at the bottom, for example, it says recommended area for compression. What that means is in a DVT exam, you have to push down on the leg to compress to perform that exam. And it even tells you when to do that. And you can see here in a second, as this user moves the handheld probe around,
press start compress.
It literally guides them to go where they are. If the veins are seen not to be centered, you see that yellow line. It even tells them, hey, these veins are not centered into the screen. You need to move them. You need to center the veins.
To record the next.
And then this is the recommended area where it recommends you do a compression.
10 seconds. During the 10-second countdown, press down slowly with the probe multiple times to close the veins. When the green highlights disappear, press a bit more. Afterwards, you will see a loop of the video recording to review the compression. If the veins are fully closed, select compressible. A compression on an actual thrombosis in the common femoral vein would look like this.
And I'll just skip this because otherwise it's a bit too long, the video, but I can send you guys a link to have a look at the end. So once a scan is performed and completed, what happens is that this, I hope you can still see my screen. It will go up to our dashboard and it can get reviewed. So here is what that dashboard looks like. You can imagine like a radiologist or an expert basically logging in. They have a work list, they click on the first exam, and immediately they see the ultrasound images. There's cine loops there stored. And in this case, it's a DVT exam, so you'll see compressions, and then they can rate the images and even provide a diagnosis potentially if they wanted to. So here they can say DVT or no DVT. In this case, for example, it's really obvious because a full compression was done and there's no thrombosis in the common femoral vein, for example. And so they say there's no DVT in that section of the leg, essentially. And this matters a lot because, again, I apologize for the way I'm sharing these slides. And that matters a lot because what happens is if you're able to do this, you can simplify. In the DVT case, you can simplify the clinical pathway significantly. So if you have, for example, a nurse performing a scan as a patient coming into the A&E clinic, you can avoid having to send them off to radiology to perform to the sonographer or radiologist to perform the scan. Noting that 90% of the scans are generally negative anyway for DVT. So therefore, you can seriously reduce the clinical pathway, and we have studies running on for that use case. But before I jump into that, I just also want to say that we are providing a training solution, meaning that it's not just a DVT case. We're also doing lung, neck, wrist, abdominal ultrasound scans, so various different scans that we're developing to support healthcare staff to learn how to perform ultrasound. And now it makes sense that I go into the DVT case. Again, I'm sure this particular audience knows DVT is a huge problem. VTE leads to a lot of deaths, more than breast cancer, in fact, and AIDS and car accidents combined. And as I just explained, if our technology is used, then potentially we can seriously reduce that clinical pathway and hopefully improve patient outcomes and reduce costs. In fact, we've even published a Nature paper on this exact use case, and it shows high sensitivity, specificity, and reduction in cost. And we're running multi-centered clinical trials with Oxford University Hospital. We're in 5 trusts already in that particular application, and we're expanding across Europe. We're also backed by the Wellcome Trust and the EU, and we're working with obviously NHSBT and various other people in the NHS. But each trust we work with, outside of this study, we're also working with other people from a training perspective, not a diagnostic perspective, as an example. Here you can see some pictures, and I just took them recently, so I like to show them off. This one I took yesterday at King's. So we have Simon there holding our software. I just taught him on how to use it, like a brief introduction, and he's able to perform scans now. And there we have Gemma also doing the same thing, and she's at Buckinghamshire as well. So our technology is being used at least in a clinical trial setting in the UK, but for training purposes, it can be used immediately. In this particular case, it's a specific study looking for DVT diagnosis, basically. And yeah, of course, you guys can have a link to read the Nature paper we published. This paper in particular was retrospective, and the work we're doing right now is prospective. So we're scanning patients in real time. That's it more or less from me. I'm happy to take questions and perhaps have I don't know how this format is, but I'm happy to have a very quick discussions about how we can help and if there's any interest from Wales or from you guys when it comes to this type of technology being used.
Thank you so much. That was really, really interesting. I'm sure everybody found it equally as interesting. I'm just wondering, has anybody got any questions? Oh, I can see one hand going up. Subami, do you want to jump in with your question?
Yeah, thanks, Dalith. Hi, Fuad. I'm Shubhmay Ghosh. I'm an anaesthetist by profession.
Mm-hmm.
I'm also lead for quality and safety at our health board in Howldar University Health Board.
Mm-hmm.
So with the app, you've shown us its usage in DVT
Mm-hmm.
diagnoses and perhaps teaching. So currently, duplex ultrasound is used, and it's got a 95% sort of success rate with DVTs, particularly with large veins above the knee. So how is your app different from that perspective? Because the duplex would show the red and blue colors as well, similarly with the sort of compression functions. So yeah.
So I want to be clear. We follow the standard guidelines, right? Compression ultrasound has a 95% sensitivity and specificity, roughly, depending on, if you add duplex, maybe you can slightly change it, but generally speaking, compressions is actually the qualifier. That's the key thing. Duplex is neither here nor there. Like, I mean, Doppler itself may or may not be useful, but that's a separate thing. I don't want to go into that. But the main thing is compressibility. That's the main way to rule in or rule out DVT. And we literally said, well, what do radiologists do today? And can we enable someone else, like who's not as well trained, who doesn't know how to do ultrasound, to also perform the exact same scan? So in fact, what I showed you there was nothing other than a compression ultrasound for DVT. The usefulness of the software is the guidance piece. So essentially, it guides you to perform the scan. So if you don't have that thorough experience, if you haven't gone to a course and you're say certified to perform the scan, you can use our software to guide you to perform it, which is why we also have that review that I showed you briefly as well, where a radiologist can look at it just as a double check. For example, if they compress and it's actually a Baker's cyst, it's not a DVT, that may make a difference, right? From a safety perspective, you don't want to anticoagulate someone necessarily if it's not a clot. So we do have that safety review first. But in this study we're running at Oxford, we're actually measuring all of these outcomes. So sensitivity, specificity, etc. There shouldn't be a big difference. In principle, it should be as sensitive and specific. In particular, it's as sensitive, that's the most important thing, as just normal duplex ultrasound. And we can do full leg. Actually, we're extending the software to do full leg, so in the calf as well. Right now, it focuses on proximal DVT, so from the common femoral vein down to the popliteal, roughly. I hope that answers your questions.
Yeah, it does. I was just thinking, usually people who go and try to do something about a DVT, if you like, and they are trained in sort of ultrasound. So it's trying to figure out how this would be helpful. But I can see the avenue that perhaps for junior trainees, it could be quite an exciting way to try and use it as teaching methods. Yeah, yeah. Thanks for the answer.
No worries. I should conclude with DVT is the key thing. It's a quick rule out. That's what we want, right? For DVT specifically, I mean, ignoring the other scans you can also perform. But if you want to do, if you have a patient, they're waiting in A&E, really the probability of having them actually having a DVT is very low, right? Just the baseline probability is low, and then 90% of patients don't have it even after they get a positive D-dimer. So it's just a waste. Like if you think about just the numbers, it's a waste of time and money basically. Because at Oxford, I remember they were looking at something. We looked at the stats, 2,000 plus scans, and I think they had 200 confirmed clots, and many of them weren't even a proximal clots. You have to even reduce that number. It might be distal, so they don't even treat it. So I guess what I'm saying is, for 90 to 95% of patients, you just want to rule it out. Basically, you just want to see is it actually an important scan to have. In our minds, a positive or inconclusive case, we would still send them for formal ultrasound, but you can really, that bulk of 80%, you could just probably screen them out, and that's essentially what we're running studies on. But that's really a diagnostic use. If you just want to use it for training for normal trainees, of course, that's a different sort of use case, because you're not really making a diagnosis decision. You're just training them to do the scan itself, and that can already be used today. Like I can give a trainee now our software, and they can practice to do ultrasound. Yeah.
So thanks, Fuad, and sorry guys for lingering on. I just wanted to ask another thing from you, Fuad. Besides DVT, can this app be beneficial in nerve block technology?
Yeah, so it's nice you bring that up. So we're developing nerve blocks. That's one of the things we're working on as well. And that's where we have to partner basically. So our development efforts depends on the requests we get from the NHS, right? From people like you who say, hey, I would like your technology to do X, and then we build that model. Currently, we got a lot of feedback on vascular access. EFAST is big for emergency, which is another scan to look for fluids. AAA, aortic aneurysm. We got wrist fracture detection. So we're running studies in Germany, for example, to detect wrist fracture detection for pediatrics, because you can rule it out with ultrasound, or at least you can detect wrist fractures with ultrasound without sending the child to X-ray, which is obviously a good thing. So there's a bunch of, the way we work essentially, and what we're looking for is literally to partner to say, what do you guys need? How can we develop it? Exactly how does it fit within your workflow, so that we don't develop blind? So the DVT case, for example, very much Oxford Hematology Clinic, like we worked very closely with them to make sure it fits their workflow. And then we are obviously happy to work with you guys as well to make sure whatever we develop is useful for your specific institution.
Thanks, Fuad. Thanks.
No worries.
I think that's really welcoming to hear, because I think, you know, for us and our purpose of our AI special interest group, etc., is that opportunity to bring people together so that we can really talk about the issues that people are facing in Wales and the solutions that we're looking for, and talk to industry, sort of provide us with your perspective and how you could overcome those. So I think that's a really interesting part of the discussion then. I think most helpful for us, because I think that's the opportunity that we would really welcome.
Yeah, from an industry perspective, I think I love it, because I think there's a big gap between what industry, quote unquote, thinks they need to develop and what the actual healthcare systems really need and what's really important for them. And what I'm trying to do essentially, at least in our company, is really bridge that gap. We don't want to even touch any code or build anything until we have a crystal clear, like, what happens, you know, let's pretend X exists, how would you use it? Because we're engineers, we'll do the magic to build it or whatever. Like, it might take us a few years, we might raise a few million on it, whatever. Like, that's less important. What's important really, if it slots into the institution, because what happens very frequently, and I'm sure you guys know this, is you get some technology company building some tech which then isn't actually useful, right? It doesn't reflect the reality of the situation, and that's what we're really trying to avoid. So for us to work together, essentially, we need a very committed, so for each say trust or institution, that we have to have a champion, someone that's very committed to do something in the long term for us, like who's committed for a year, for example, and say, okay, I'm going to lead this, this is what I need. And then obviously, I mean, I really should mention this is really important for everyone to also think about, which is the economics of it. So for example, nerve blocks was just mentioned. The first question, two things came up to me when I thought about it. A, it's definitely something we can build. In fact, it's more trivial than what we've already built, so we can do it. But the second thing I thought about is it economically feasible? Because a lot of things are nice to have, but actually when you build it, and this has happened many times before, where you build something and people think, oh, that's very nice, but no one actually ends up paying for it, right? And so that to me is also a huge thing. So I think the people we also have to get on board are either the CCGs or whoever actually ends up paying for technologies, because what ends up happening is you develop it, everyone gets excited, but then if the health economics don't work out, then it doesn't get adopted anyway. And that may have nothing to do with either clinical outcomes or the staff or the company. It's just economics, like it just people can't afford it, or the price is too high or something. So in the DVT case, not to belabor that point, we from the get-go in our preclinical work, we did a health economic analysis. Like we didn't finish all this stuff and then decided to run the economics. We did it from the beginning. Actually, Sheffield helped with this with Professor Goodacre, who used to do the health economics of DVT in general, so they have lots of experience with that. And we made sure that the way the technology works slots in with a current clinical pathway, and then we measured, what the sensitivity and specificity would have to be for it to be cost effective for the NHS, etc., etc. So like that's the way we want to attack this, which is multiple angles. What's the unmet need? What can it get built? And then the final thing is this economically, do the health economics work out? Who's going to pay for it in the end? If all of those three things are put together, then this has very huge transformational power, in my opinion, about changing and improving patient outcomes.
Thank you, that's brilliant. And Sherry's just made a point there in the chat to say that's a fantastic observation, because you're absolutely right. That perception of need is not always aligned to the reality. And again, I think this is something that we reiterate quite a bit when we're talking to industry about that involvement right from the get-go, because there's all the other considerations around interoperability and everything else, and the systems that are being used on a local level. So it's so key to just make sure that we align all those priorities.
Yeah, we can all get overexcited, doctors and engineers, we all get very excited very quickly about some type of technology. I heard a lot of people on my end saying, oh, but DVT is so niche, but I'm like, yeah, but it actually solves all the problems. I could, in industry, if you say the word cancer, for example, everyone throws money at you, but it's like a generic thing, if that makes sense. So there's a lot of excitement about trying, and it comes from a good place. People are trying to help, right? But sometimes it's a little bit misguided. And I think, thinking about the problem very, very carefully about what we're trying to achieve and is it feasible is so important for all sides, to be honest, because otherwise, we end up wasting a lot of time and energy. But can I ask people here on this call, like, have you guys implemented or worked with industry in the past? Is this new, like this setup of this, what is it called? The artificial intelligence call that we're on now? I'm just curious what your experience is with working with industry.
Is anybody wanting to come in on that? Sherry,
Sure.
you've raised your hand there.
Yeah, probably a false hand and not very fair, because I've just put in my message. This is my first time on this call. I'm Sherry Methuen, Head of Partnerships, working with Delith. And actually, I planned to have a conversation with Dell. I don't know how long this group's been going and whether kind of the objectives are very clear. Maybe it's a good time to kind of regroup and see how this group can really be used to identify what the priorities are, what the needs are. And I'm really sorry if that's already in place. I'm kind of not sure, but it seems like an amazing group. And whilst kind of presentations from industry at this point are great, maybe it's a time to all come together with industry and with health and social care to start by identifying what the challenges really are. And forgive me if that's already been done.
No, not at all, Sherry. I think everybody on this call would probably agree with that, because what we want to do is make sure that we're best using people's time and energy to focus on where those areas of need are. And I know that we've had discussions in the past around what are the priorities for people, what are people particularly interested in, but also what work is currently being undertaken across Wales that we can learn from and share as well. And it's just trying to find the right forum to enable all those conversations to happen. And I'm going to do a shameless plug at the end of today's call about the Simply Do online community forum that I really want people to engage with, because I think these discussions don't necessarily need a meeting to take place in. I think we could be doing this online when people have got the opportunity, and identifying and just sharing more about what they're actually doing to get keep that conversation alive and keep it current.
And Del, I think it's also worth mentioning that kind of the hub, we're just reviewing all of our kind of online platforms, what's working, what's not working. And actually it's a bit of, if we don't use it, we might lose it. For me, I think the Simply Do platform is a great platform for sharing across a community in a safe environment. So again, maybe time to really think that, can we use the Simply Do to its full function? And will it help to achieve what we're trying to achieve?
Do we have anyone who, I mean, it would be good, in my opinion, from an industry perspective, to have what I call key decision makers, and not necessarily just clinicians. I really mean payers, those people because I don't think I've ever spoken to a payer, which is crazy. Like, been doing this for quite a few years now, and they seem to always be somewhere else when I'm like, okay, isn't this sort of exactly part of what you need to do, because this is literally solving your problems? But anyway, so what I mean is there a way we can set up, like, even if we take a simple use case like the DVT one, let's say we wanted to implement that in Wales. Now, I know how to do that perhaps in England, but is there anyone on this call who makes key decisions on costs, on adoption of technologies? Because that's really what we're talking about, right? We're talking about technologies that we want to implement in Wales, right? That we can use for various different things to support patients in Wales. But is there anyone on this call that actually makes the key decision to adopt or use technology, or is heavily involved in that? See, I guess not. See, that's not my point. So it's like you have clinicians speaking to each other and industry. Oh, okay.
Yeah. But, so for what? I'll have to leave to my next meeting, but just giving an idea as to how perhaps it works in health boards. Yeah. So any kind of technology, should we say, or innovation would need to go through a couple of panels, should we say. So the first entry route is to do a presentation at the health board. It's usually something along the likes of AI or anything which is digital IT related would perhaps be best to liaise with the IT department. And from a clinical perspective, all health boards have a very important role, and that's the CCIO. So this is the Chief Clinical Information Officer, who is a doctor who's trained in information technology and digital. And then the route basically is procurement. That would be the entry into the health board. But there could be other ways. But this is what mostly the ways to enter into the health board's, should we say, business areas, if that makes sense.
Yeah, but what's not clear, and this is across the UK in general, what's not clear in theory, these people exist. I don't know who they are, even though I've been doing this for 5 years now. They're not. It's not like their email is there and say, "Hey, I've got open office hours. Like, contact me."
You'll have to look for that, Fuad. It's not something which will come to you. You would have to go to them to find out. And perhaps the best way is to contact the IT department in the health board. There is a clear structure in most IT departments. In our health board, we've got so there's a structure. There's the director of finance who is in control of the IT services, and perhaps if you link up with an IT person in the health board, they could easily you could trace up the ladder, the decision-making ladder, should we say. But that CCIO role is quite important. I'm really sorry, guys. Great to be on the call as usual. Thank you, Delith.
That's all right.
I'll see you all soon. Take care now.
Thank you. And I'm gonna move us on. I'm not doing a brilliant job as chair. I've already we've overrun a little bit, so I'm gonna move us on quickly now, just so that Rob has an opportunity. But what I'll say in the meantime is, we can take a conversation offline, just in terms of how we can introduce innovation across the health boards in Wales, and we can talk about that in future. And I think I'm okay in saying we'll share your presentation with the group, and we can put it on our online platform as well. But yeah, I'll hand over to Rob now. Thank you so much for that. That was really helpful. And Rob, shall I let you introduce yourself? Is that all right?
Thanks, Delith. Thanks for inviting me today. Can you hear me okay?
Yes.
Yeah. Okay, so I'm Rob Altram from Nova Bioelectrics. We're in Cardiff. We're the UK branch of Senso Medical, a company established in Nazareth in Israel. And we basically design and manufacture devices that interface with the brain and the nervous system. So that can be wearable devices, implanted devices, deep brain technologies, gene and cell therapy, mapping and delivery systems. But we're not really an end product company. So we don't really have any off the shelf finished products that we sell to hospitals or universities with a big group of sales reps. We're not like that at all. We're one step back from that. Think of us more as a outsourced R&D, prototyping, product development, regulatory, batch through to scale up, manufacturing services company. We're really strong in innovation and R&D. We get a lot of help from the Israeli Innovation Authority to help develop new technologies, new platforms, and every pound that we make in revenue, we reinvest in technology. So we think we're pretty unique. There's no one else in the world, I think, like us, because we're so invested in innovation. So whilst we're not an end product company selling medical devices to hospitals and universities, we have developed in-house some platforms which are one step away from a medical device. So if our clients who are typically clinicians, researchers, scientists, R&D departments, early stage companies, if they sit on one of these platforms, then because most of the development work has already been done, then the risk is much lower, the time to market is much quicker, and the cost is much lower than doing something from the ground up, which we can also do. So these platforms, we have one which is called Biopot, which is essentially an EEG platform. We have another platform called Biochem, which as you can tell by the name, it's a biochemistry platform. So, and then we have a non-invasive a nerve stimulation platform called BioStim. So these are platforms that we've developed in-house, and we offer these to clients. So all they have to do is do final customization, and then they have a viable product, or at least they have a proof of concept. Now, these platforms are scalable, they're open source, so they're using latest Bluetooth technologies. So we can help the clients get the data from the platform over to the other side. So this is really, we're now talking about next generation neuro devices. And so we offer these platforms. I think of these platforms really as the engine to your medical device. So imagine it's like a Volkswagen will have multiple brands. It will have Skoda, it will have Seat, Volkswagen, Audi. The platform underneath is pretty much the same. So we can really help people achieve their aims in record time, really. We also are paid by our normal model is fee for service. So we're paid by product development milestones. We make sure our clients hit those milestones, because at the end of the day, if they don't, then the investors lose interest. So that's it, really. You know, we want to connect with the network in South Wales and in the UK. We want to start working on projects so we can help people commercialize their ideas, or to help people create a new medical device in the neuro space. We are very focused in neuro, but we do other things. But we are, you know, essentially a neuro device development partner. That's it.
Thanks, Rob. Has anybody got any comments? I can't see any questions in the chat, but if anybody wants to raise a hand and ask any questions. Mark.
So thanks, Dale. Hi, Rob. So thanks for that. It's just like practically then, you know, how do we potentially work with you? You know, what are the sort of steps? Because I think you know, a lot of the challenges that we sometimes have on this the development side is sort of understanding how we make it sort of like mutually beneficial for all sides. You know, we maybe get sort of like a clinical lead on things versus, you know, providing access to clinical data or whatever, and just try and think about the governance and the sort of practicalities around that. Because I guess the challenge is how to get to the right clinical team and what's sort of in it for them. And I don't always mean financially, you know, don't it's not always like filthy lucre, but it's just like practically what's the hook for them to access these things and to work with you or you know, your extended network.
Mm-hmm. Well, just as a bit of background, really, I think there haven't been major innovations in neuromedical devices for a long time, and there's a big barrier to entry. There's the regulatory aspect, there's the time to market, and there's the cash burn and valley of death that everyone's aware of. So that's kind of the if you like, we help bridge that gap. So how we typically work, I mean, I've been with Sensor Medical and Nova Bioelectrics for 3 years now. You know, we work with quite a wide variety of people. I would say probably most of them are sort of early stage companies. So these could be clinicians that are perhaps chief scientific officers. They have maybe one group we work with in the US There's a neurosurgeon that actually quit his day job, by the way, to become the chief scientific officer of an early stage company. They had some initial funding, some seed funding. They had an idea, and we helped build a product for them. So that's one case of maybe a clinician being involved in an early stage company. I'm not sure how much of that goes on within the NHS. I suppose people are too busy doing their day jobs to maybe get involved. But maybe the landscape will change going forward, and maybe there will be more clinicians actually being encouraged to participate in some way with early stage companies, whether that's as a chief scientific officer or in some other capacity. But I would say most of our work is really with early stage companies or startups. Also established R&D departments, because the big corporates, although they have massive R&D departments, they're not actually that innovative. So rather than develop their own R&D or their own technology, they tend to acquire the innovative companies. So I won't name and shame any corporates here, but the fact is there's not an awful lot of innovation in the neurospace, and we help established, corporates create a medical device, believe it or not, because they don't necessarily have the expertise in-house, because they historically acquire technologies rather than develop them. So yeah, early stage companies, established R&D departments, but we do also have a different way of working. In some cases we work with universities. So for example, I mentioned we have some platforms that we've developed. We're looking to update those platforms, to introduce new platforms, and in that type of scenario we could work with the university or with clinicians to develop a new platform that could be in the neurospace. So I know, for instance, we have in the past worked with Fraunhofer in Germany. They were creating a new electrode technology, and we were seeing how that can work with our platforms. Another type of model that we work to is sometimes if we develop a technology and it's looking vertical rather than horizontal, then we might spin out a company ourselves. And a good example of that is a neurosurgical technology that we've developed in-house, where we've actually spun out a company to commercialize that. But typically we're a horizontal company and not a vertical company. Does that answer your question, Mark, or have I not really?
No, that's great. Yeah. Thanks, Rob. So there are, the range of opportunities, I think basically, but as you say, you've got your core focus, and then just, I guess opportunistically, maybe that's not quite the right word, but just depending on circumstances, as it were, you may take a slightly different approach. But yeah, that's great. Thank you.
And sometimes there could be groups that have got a proof of concept, a minimum viable product, but they can't take it, over the line. They can't. They struggle. For example, with quality management systems, or their device needs optimization. It needs to be scalable. That's a big body of work that they need to do, and they might not have the expertise. So that's how they can use our expertise and our platforms to get to the market very, very quickly.
That's great. Thank you.
Thank you. Has anybody else got any sort of comments or questions for Rob? We can share Rob's contact details with the recording, etc. So if anybody does want to get in touch, then we can facilitate that for you.
Thanks.
I'm not seeing any more hands or questions coming up. Oh, we do have one from Hugh. Shall I read it out for you, Hugh? So Hugh is doing a project on stroke detection device in real time. Oh, you can ask your question if you want to.
Hello, sorry, Rob. Yeah, I'm trying this project. I'm a clinician on stroke, and I've been trying to get an industry to design. I have an idea, an early stage of idea. I am trying to find, like what you said, you do prototyping, you do design on Eurospace. So I was really interested on this project or on your company, on your company, that maybe this idea which I have, this is a stroke device that can detect stroke in real time, so we can detect the emboli or embolus, as you say, that it's emitted from the from the heart and it goes up to the brain, and then with your neuro deep like science and technology, I think we can detect stroke on the technology you have. So it's just an idea which maybe you on your company can build that prototype, something like that. I'm not really good in technology because I'm a clinician, so I'm just having this idea, which a really good strong case, I think, for stroke community, because this debilitating has been there for a while. No one can like I would say the time element of stroke. We want to intervene with the three eyes, because we say that stroke is a brain infarction. So with the three eye, I would say injury, ischemia and infarction. So that's three stages of the process of being of stroke. By the real time, on your technology, maybe we can intervene in every element, like the ischemia to sit on. We can intervene, or we can do something in the ischemia and in the infraction process. In every element, maybe the technology can detect, and then identify the right treatment and also the right intervention. And I would say, and then hopefully the stroke can be detected and have a real, intervention that can be put on the algorithm, on the pathway, I would say, with the technology you have. So that was my my idea on what on the project I'm trying to I would say to build on. So
that sounds really interesting. I mean, we are doing a couple of projects in stroke. It's one, I have to be careful because of NDA. One's like a wearable device, minimally invasive stimulation of the cranial nerves to promote blood flow, and also stimulation of the vagus nerve near the ear. So this is very much in the early stages. Also doing another application, another project starting off in lower back pain, but could be used for stroke, traumatic brain injury, depression. So yeah, in terms of expertise, we would certainly have that expertise. A lot of our clients actually come from a data science background. These could be groups that are maybe a software, maybe even a software company that wants to vertically integrate and have a device, a full medical device. So we would help them with the data integration and the hardware, electronics, powering, that kind of thing, as well as the manufacturing services. So yeah, I think what's best to you is maybe we share emails, and I can send you some further information on our platforms. And I guess the biggest challenge in a project like this would be, building the team. So you'd probably need someone with a data science background. You could be the clinical lead, and then we could be the engineering or manufacturing lead. So So it's building the team and obviously getting the funding, applying for the funding. But
Okay, of course, yeah.
as we're based in Cardiff, you know, I think there were the SMART grants. I think they're being replaced. Am I right, Kelly?
Yeah.
Oh, I'd have to check with them, but
Yeah.
I have got a little bit of news around funding from one of my colleagues to bring into any other business, so might be worth listening out for some news coming up now.
Okay, great. Well, it's nice to connect with everyone, and Hugh, we can share, you know, further information after the call.
Oh, thank you.
Thank you.
This is non-invasive procedure, non-invasive.
Non-invasive, yeah.
Yeah, we just use some, you know, electrodes. Thank you. Thank you. Yeah, thank you. That's all.
Brilliant. Thank you. Well, I think that leads me quite nicely into then my other business around some funding opportunities. So I think most of you will have met Sarah, one of my colleagues at the Life Sciences Hub, who keeps an eye on all the funding opportunities. She unfortunately can't be with us today, but she has asked me to pass on just a couple of really interesting points. So there is an SBRI healthcare funding call. It's got 4 open competitions at the moment, one in health inequalities in maternity care, and that's closing 6th of July. Early stage work up to £100,000. Autism and learning disabilities, again closing 6th of July, early stage work up to £100,000. Respiratory diseases, bit longer on the closing date, that's the 26th of July, and they're looking at real world testing and implementation, and that's up to 500,000. And then finally, the prevention of cardiovascular disease, again closes 26th of July, looking at real world testing and implementation up to 500,000. And Sarah says she'd be more than happy to help anyone interested in applying with a bid review. So if people have got applications, she'd be happy to have a look at them. And then also, I don't know if many of you have signed up for our Simply Do platform, and I'd encourage you to do that if you can, just purely because as we see updates coming in and requests for action and sort of interesting bits and pieces, we are popping them on the forum, so you'd get them as soon as we're aware of them. But one thing we have popped on there recently is a webinar held in conjunction with the European Commission and the AI Data and Robotics Association. So they have a webinar on the 17th of June. So I think that's this Friday, isn't it? What day are we today? Tuesday, so Thursday. And this is an information session with an option for to pitch projects to follow. So all the details of that webinar are on our Simply Do platform. I will send all the details of the funding opportunities out with the recording, but conscious that there's not long until the 17th. So if anybody wants those details, please let me know and I can share them with you. So those were the couple of points from Sarah. Has anybody else got any other business? I think, oh, Simon, you've got a hand up.
Yeah, sorry, just a quick one. So those who we haven't met, I'm a university lecturer who specialises in a particular part of data science, way of seeing this sort of shape of data. Exciting personal news is that I've sort of got a promotion now working for the University of Manchester. So I've now left Swansea. So that's exciting. They liked what the data was doing. I'm still very hopeful that they'll be able to do some projects in the health space. But my question, therefore, is: although I am still living in Wales, am I still allowed to come to this group, given that I'm no longer working for a Welsh university?
I'd have to look at the terms of reference, but I think we would welcome the opportunity to learn from people across the border. I mean, please, if anybody's got any objection to what I'm saying, see, I'm taking advantage now. I'm sat in the chair's seat. I'm making all sorts of decisions, but I think that would be absolutely fine, because I think we'd really welcome the opportunity to learn from each other and more widely. So I think, unless I'm hearing very loud objections from anybody else. Oh, good. Sherry agrees with me, and I'm not seeing anybody saying no. So I think that would be fantastic. And congratulations on Malcolm sending a little note to say he lives in Wales but works in Leicester. So that's all fine. He sneaked in there without saying anything. So that's great.
No, thank you. That's good. Then in that case, I shall continue to. I need to get onto the Simply Do. And
that would be brilliant if I could encourage people to do that, because I just find sometimes there's things that we want to let people know, and I know things drown in people's inboxes, and it's just really great to be able to sort of have some of those conversations. I'm conscious of time, and we're coming to the close of the meeting, but I think some of the important discussion that I'd really like to have maybe at the next meeting would be a bit of an update to find out what's happening in your local areas, the projects that people have got underway, and maybe if people can share some information around those, but also some of that conversation that we had earlier around priorities, just finding out what people are working on or would like to have more information on, because obviously at the hub we're seeing lots of industry, we're approached by lots of people with some fantastic innovation, but we need to know what areas of work are really key for people, so that we can ensure that we're aligning those priorities. So if anybody's got anything now in the last sort of minute we've got as we're online. Otherwise, I'm going to say thank you so much to our presenters. That was really